to calm me down a lot long.
Director Shenning, you are welcome to unmute yourself and give some introductory remarks.
Good morning, everyone. I want to thank everybody for signing in. We just got done the first day in briefing with A shift that's on today. So I know a lot of you guys I just talked to just a few minutes ago. For the other people that are signing in, this is a new platform for a lot of us. I think you guys are going to find this interesting. It's something that in EMS we've been doing some training with before. It allows us to bring in and talk about some confidential cases that we do with a lot of cases in EMS if we're doing a case review or something like that, and it allows us to bring in some subject matter experts remotely. This morning I have the privilege to introduce two people, which is Dr. Sean Barinholtz, who you'll see on your screen, and also Dr. Dave Vitberg. Dr. Vitberg, both of them are associate medical directors. Dr. Vitberg is deputy medical director, and he also is an attending over at GBMC. Where he's at over there, he was one of the physicians that took care of some of the COVID patients that were in the ICU over there and subsequently discharged. And he wanted to share some of his information. I think it's important as we look on this because this is something we really haven't dealt with before. We went into this not having a ton of information. We're a few weeks into this. We have more information, but still not a ton. However, we do know things like PPE works, how we're going to approach patients. The whole infectious disease isn't quite in the realm of EMS. It's part of it, but certainly not what we train for day in and day out. And I think what you'll hear from Dr. Vitberg a lot of times is that they had some of the same anxieties when they're dealing with them. They do a little bit more with infectious disease and everything, but some of the same anxieties of how we're going to approach a patient, what happens when I'm going into and out of a room. So a lot of that being in the healthcare industry it's shared between those. And I want to thank him for putting this presentation together, Dr. Barinholtz for moderating it like he's done so many of these before. And with that, I'm going to turn it over to them for this training. Thank you guys very much.
Thanks, Director Shenning. For those who I haven't met, my name is Sean Barinholtz. I am an adult anesthesia and ICU physician at Hopkins. I am an active volunteer at Pikesville, and I have the honor of serving as CAR 609 in the medical director's office. On behalf of Dr. Pollack in the medical director's office, thanks for joining. On behalf of the EMS office, Director Shenning, Captain Stewart, Captain Natz, thank you as always for your support. So it's a couple of ground rules. I will be able to mute all. Feel free to mute yourselves as well when you're not talking. I will be monitoring the chat function in the bottom of the platform. You should see a chat box. I'll be monitoring that. If you have any questions or if you're having any concerns or issues, feel free to send a chat. You can send it directly to me for operational issues by selecting instead of everyone. You can scroll for my name or it may say host. You can send me a direct chat and we can communicate that way as well. Feel free to ask questions. You can ask questions to the group. You can send them to me directly. I will be the one to bring questions up to Dr. Vitberg to try to minimize potential background noise. Yeah, and I think that's it. So today we have a pleasure of having Dr. Vitberg join us. Dr. Vitberg is a board certified in emergency medicine, critical care, and EMS. He's currently the Deputy Medical Director for Baltimore County Fire Department, a member of the R. Adams Cowley Shock Trauma Center GO Team, and Division Chief for Medical and Surgical Critical Care Medicine at GBMC. Dr. Vitberg, thanks so much.
Thanks, Sean, for the introduction. Thank you, everybody, for joining us on Sunday morning. First off, just want to say how much I appreciate all of you being here, taking some time to listen to some information, some of which you probably heard many, many times, some of which will probably be new to you. What we're going to go through today is not just a little bit of background about COVID-19. I'm going to give you an insight into how some of these people are doing once they get into the hospital. Some of them doing very well, some not so much. I want to talk to you a little bit about how we've dealt in the hospital with change and uncertainty in this evolving crisis, how I personally have overcome the anxiety of taking care of multiple positive patients at the same time, moving in and out of their room, feeling confident that I'm putting on my PPE correctly, taking it off, and then I can go home at night and be with my family and not infect them. I want to also give the group a little bit of insight into triage in the hospitals and what might happen if and when we do get to the situation where in the pre-hospital realm, we invoke the pandemic triage protocol, what that looks like on the inside once a patient gets here. And then I want to share with you just some thoughts about what I consider the silver lining in all of this. And I really do believe in the power of positive thinking. And I've just been very impressed by how much positive has come out of this stressful experience. So we're going to get right into it. And again, I would encourage everybody, if you have any questions, please put them in the chat bar, funnel them to Dr. Barinholtz. And I could talk and talk, but I would very much like to prioritize any questions. So if you have a question, send it to Dr. Barinholtz. He'll unmute himself and he'll introduce the question. So I think it's important, we are clinicians, we are healthcare providers, and we are not the pre-hospital phase of this. We are an integral part of the delivery of care for this pandemic. So I think it's important that we give you guys a little bit of a clinical update regarding COVID-19. So real quick, and not to bore you or give you a seizure, but COVID-19, it's an RNA virus. It's part of a family of coronaviruses, 4 of which cause the common cold, 2 of which are more severe, and they're known as SARS and MERS. And SARS and MERS cause epidemics and very high mortality rates. So SARS, which stands for Severe Acute Respiratory Syndrome, often refers to the original outbreak in 2003, but the coronavirus is a relative of SARS, and SARS-CoV-2 is actually the name of the virus that we are dealing with right now. The clinical illness and the syndrome of illness that SARS-CoV-2 causes is known to us commonly as COVID-19, coronavirus disease 2019. Very interestingly, it looks like the virus actually enters the pneumocytes, the lining of your alveoli in your lungs, via the angiotensin converting enzyme 2 receptor. So there's an ACE receptor in your lungs. And those receptors are also found in the gut. And the reason I bring this up is you'll see in a few slides when I show presenting symptoms both locally at GBMC and Hopkins and around the world. It's very common for these patients. It's not uncommon for these patients to have both respiratory and GI symptoms. And sometimes the GI symptoms actually give a warning that the respiratory symptoms are coming. So the portal of entry of SARS-CoV-2 or COVID-19 is the ACE receptor in the lungs, which lines the pneumocytes, the cells that line the alveoli. And as the virus enters those lung cells through those receptors, it causes changes and destructive changes to the lungs, which can cause intense inflammation and cause patients to become rapidly hypoxemic, short of breath. Some of you who are diabetics or have high blood pressure may be on medications like lisinopril, fasinopril, captopril, which are ACE inhibitors. And what happens when you take those medications is ACE inhibitors prevent basically the conversion of a chemical called angiotensin 1 into angiotensin 2. And if we actually disrupt this pathway by taking an ACE inhibitor, it causes more receptors to show up both in the lung and the blood vessels, more ACE receptors, because it says, hey, where's that active angiotensin 2 that normally causes my vessels to constrict? It's gone. And so it counteracts that by creating more receptors to look for that chemical. And so one of the key strategies that we adopted early in the hospital in treating this disease is we do not continue to administer ACE inhibitors when patients are on ACE inhibitors. Because we don't want those receptors that are found on the lung and the gut that are potential portals of entry for SARS-CoV-2, COVID-19. We don't want more of those receptors available for the virus to enter the body. So we typically hold ACE inhibitors. It's important to know that COVID-19 is mutating. And the picture on the right shows basically genetic mapping that's been done of the virus, starting with the blue back in China, to a lot of the pink reddish dots are kind of what the genetic sequence looks like now. The initial virus was thought to be much more virulent, more powerful, more effective, much more capable of causing severe disease. There are those that believe that the mutations that have occurred have actually made it less virulent, less infective, and less severe. But you should know that the disease, the virus is mutating, but the general approach to treatment and care is, while it is evolving, we are using lessons learned from China and then Italy and then Seattle. We're using those lessons learned right now to take care of patients. So COVID-19, when patients get very, very sick, they tend to develop something called ARDS, Adult Respiratory Distress Syndrome. And like I said before, the portal of entry of this virus is through the mucosa lining the nose, the mouth, the pneumocytes in the lung, perhaps the small intestine. And as the virus enters, it causes direct damage to those cells. And as damage occurs, you get inflammation. And in the lungs, when you get this inflammation, you also get what's called a cytokine storm. You get all these inflammatory mediators that kind of begin to rise. You get this intense inflammatory response. And in the subset of patients, approximately 5 to 6% of patients that get admitted to the hospital that do require ICU level care, we often do see them develop ARDS, which is a severe form of hypoxic respiratory failure, often with these patients needing early mechanical ventilation and aggressive critical care. It is important to note that, again, the patients that go on to develop this very fulminant respiratory illness represent approximately 5 to 6% of hospitalized patients, not of all patients. The transmission what we know about transmission has actually evolved over time. There's no doubt that it spreads via large droplets. We often talk and hear about social distancing and keeping back 6 feet. This is a great practice if you're in a fire station, if you're working. There's really not a great reason not to be able to distance yourself 6 feet between calls when you're not directly involved in patient care. And even when you're involved in patient care, it's often very plausible to distance yourself from the patient and keep yourself safe. So we have no doubt that large droplets are a means of transmission. In the beginning of this illness, there was a bit of controversy about whether or not this was transmitted via the aerosolized airborne route. That's becoming increasingly less controversial. We know that small aerosolized particles remain aloft in the atmosphere for a long period of time. They may persist in the atmosphere for hours. Thus, the guidance to run an exhaust fan in the back of your medic unit, to when you get to the hospital, leave the doors open, side door, back door, let air circulate. And you'll often get the amount of air circulations that we get in rooms when we create negative pressure rooms, 10, 12 circulations per hour or more when those doors are open. There's a little bit of kind of disagreement between different national and international guidelines. There's Canadian and World Health Organizational guidelines that say, hey, listen, you only need to wear N95s when you're doing AGPs, aerosol generating procedures. There's other guidelines that say that you should wear N95s at all times. I'm pleased to see all of our providers in the field got fit tested extremely early in all of this and have been wearing N95s, and I think we're way ahead of the curve with regard to preparation and keeping our staff safe. The CDC's official position is that the preferred mode of protection is as shown on the left, N95. In the hospital, we put a face shield over our N95 to prevent it from becoming grossly soiled, a gown and gloves, and making sure that the gloves come up over the cuff of the gown. Alternative acceptable PPE is a surgical face mask with all the other same stuff. But again, I'm thankful that every crew that I've seen come into the ER the past few days that I've been working has had their N95 on. So again, we know large droplet transmission clearly occurs. This is not controversial. Airborne transmission undoubtedly occurs. And then the other issue is contact transmission, where we talk about kind of the fomite to face route. A person who's infected or maybe even be not yet symptomatic coughs, they emit large droplets. Those droplets settle on the surface. A thin film is created. And from review of the literature, those surface films may persist for up to 4 days. And then somebody might touch that surface and then touch their face and then become infected. Thus, the guidance to avoid touching your face, particularly important when you're taking care of patients, PUIs or confirmed cases. So how do we protect ourselves? Large droplet transmission. That's why we put surgical masks over patients' faces as soon as possible. That's why we put surgical masks over any sort of oxygen delivery device that may lead to more droplet production or aerosolization, like a nasal cannula, like a nebulizer. For airborne precautions, we wear our N95, particularly when taking care of patients, be it in a vehicle, a confined space where we're next to a patient affecting rescue, be it in the back of a medic unit, we should be wearing our N95s. Contact transmission, I think the department has done an excellent job of getting instructions out there regarding decon procedures, using your bio wipes, wiping off surfaces, keeping things clean. These are things that we should be doing on a day-to-day basis. And what I'm going to tell you later in the talk And what I find to be one of the silver linings in all of this is we're actually doing a lot of common sense things that we should probably be doing every day, even in the absence of a horrible pandemic. And one of the nice things that we're seeing in the hospital is we're seeing less and less of what we call nosocomial C. diff infections, so infectious diarrhea. We're seeing less secondary infections in the hospital because we're practicing good routine infection control procedures. One of the recommendations that I just showed you is that when we take care of these patients in the hospital, the recommendation is that if they are sputtering and coughing and particularly ill, that we do try to put them in airborne negative pressure rooms. And most hospitals only have a handful of rooms that are designed to be negative pressure. Some more modern ICUs, all rooms are negative pressure. But in general, if you kind of look around the state, most ICUs and most hospitals have a smattering of negative pressure rooms here and there. So our 12-bed ICUs had 2 negative pressure rooms. We would typically use them to place patients that we suspected had tuberculosis prior to this pandemic. But what I'm showing you in this picture with the arrow is back in early March, we had our facilities folks come out to the ICUs. They punched out a panel in all of the windows, and they installed HEPA fans and made every single room capable of being negative pressure. And before the call started, I was joking around with Dr. Barinholtz how it often took an act of God to get the thermostat adjusted in a patient's room before this pandemic, and how nice it is to see, and this happened. If you look at, this is the top floor of GBMC, we turned every single room on the top floor, which is where our ICUs are located, into a negative pressure room. And we were able to get our facilities folks to do this in the course of 48 hours, which is remarkable. So when can transmission occur? I think most of us, our biggest fear is asymptomatic transmission. Transmission typically occurs during the first 8 days following the initiation of illness, but can certainly occur when a patient or one of our coworkers is asymptomatic. But then again, you have to go back to basic principles of what everybody else in the community is doing, which is social distancing, not sitting around a dinner table in close proximity to each other, frequent hand hygiene, covering a cough, and then monitoring yourself for symptoms and doing well-being checks. Patients may have, when they get their nasal swabs, their PCR test, which is the test that we use to test for COVID, maybe and remain positive for weeks even after they recover and they're not symptomatic. But the fact of the matter is that it's the viral culture which grows. We've been unable to recover viable virus after about 8 days of clinical illness. So once you become ill and you get past the 8 days, and particularly if you start getting better, the viral load and the amount of shedding typically goes way down. The risk of infectivity goes down. And that's where kind of the guidance for 14 days of quarantine, self-quarantine, or isolation comes from, is that is well beyond the 8 days at which people are generally considered most effective. With regard to PPE, I'm not going to spend a whole lot of time talking about PPE because I think there's been very good instruction and guidance that's come out from the department regarding the proper use of PPE and the imperative to protect yourself before you walk into a situation. One of the things that I want to start by talking about, which I've spent a great deal of time talking to my docs and my nurses about, is that the framework we operate under has had to shift pretty quickly. I, like all of you, being involved in EMS since I was 16 years old, now the ripe old age of 43, and being a physician and attending in an ICU for the past 13 years, my disposition is I am preloaded to run into a room when I see a patient in distress to begin to support their respiratory status if they're developing respiratory failure, to start high performance CPR if they become pulseless. That has to change. That had to have changed weeks ago when this all started. The most important thing we can all do for ourselves, the people we work with, our colleagues in the hospital, in EMS, in the fire department, is pump the brakes before we do anything. And much like and I'm not claiming to, I am an entry firefighter, I got my white tag, but much like we do the 360 to make sure there's no basement fire, and we're not going to walk into the foyer of a home and go through the floor, we have to pump the brakes and take a look at what we're dealing with, don our PPE, make sure that the gloves are over the edge of the cuff of our gown, make sure our N95 is sealed, do a little test to make sure there's some good negative pressure around our face, maybe even put on a face shield, and then go into the situation and mitigate whatever problems facing us. We have to protect ourselves before we begin to render care, because if we become sick, then each one of us is going to be responsible. There's no doubt each one of us, you, me, everybody on this call, we're all going to be responsible for treating hundreds of patients downstream. And if we take one of us out of the game, we're depriving society of a very capable healthcare provider. So pump the brakes, put on your PPE. I always recommend in my full-time place of work in the ICU that we use a safety officer to make sure that our PPE is on correctly. That safety officer doesn't necessarily have to be a designated person walking around. It can be your partner. It can be the nurse that you're getting ready to go into the room with to intubate a patient. It can be your partner on Medic 19 or Medic 325. So serve as safety officers for each other. Make sure you put on your PPE properly. Make sure you put your PPE on first before you walk into a black box situation where you don't know what you might be encountering. One of the other lessons that I've learned is, attention to detail. I think this goes to everything in healthcare, making sure you're pushing D50 and not bicarb or vice versa. The 5 rights of medication, make sure you got the right medication in your hand when you're pushing it. The same thing goes with PPE. Be attentive to detail. Make sure your gloves come up over your gown. Make sure your PPE is on. Make sure the N95 is sealed around the bridge of your nose, and you do a little leak test and make sure that there's a little bit of negative pressure that you can feel there. On the doffing side, one of the things that I find is, we do a intubation or we do a high-risk procedure, and then we feel good that we made it through without a breach in our PPE, and then there's folks talking to us through the door. You can envision that you just intubated a patient in the field, and then you're so happy that you got it done that somebody starts talking to you and distracting you with the next sequential task. I would advise against that, and if your next task is to doff your PPE, you should be entirely focused on that. You should apply some alcohol-based hand rub over your gloves if they were grossly soiled. You should very meticulously and carefully take off your PPE and then apply alcohol-based hand rub afterwards. And don't let others distract you, because that's really where the breaches happen, is when we're doffing. One of the most counterintuitive things for me has been the application of alcohol-based hand rub over my gloves. And in my practice, and I'm not going to tell you how to practice, I would follow the direction that's coming from the command staff in Baltimore County. I typically, if I have been in a patient's face, if I have done an aerosolized generating procedure, if I've had contact with secretions, and I look at my gloves and they are visibly soiled, I do apply alcohol-based hand rub to my gloves first before I take off my gloves, and then I apply alcohol-based hand rub between every step of my doffing procedure. And again, I would really, really encourage you to use a safety officer whenever possible. Signs and symptoms, I think that this has gotten much simpler. The guidance coming out in our sit-stat reports is, if you are febrile above 100.4 or have any influenza-like illness, you're a PUI. But just to share with you a little more granular detail, this is kind of a compilation of symptoms that have been reported in the literature. You'll look at the top and you'll see, indeed, the gross majority of patients are febrile when they have this illness. Many patients have cough, so fever and cough are really the 1-2 punch with this illness. But I do want you to note at the bottom of the screen that there are a fair amount of patients that will have GI distress, again, because that ACE receptor is located in the gut and the virus may enter in that manner. And then there are a fair amount of patients that I've encountered in my own personal practice that have told me they feel chest tightness and a band across their chest. And then there's a host of other kind of upper respiratory symptoms that are not uncommon. So fever, cough, dyspnea, shortness of breath, GI symptoms. And one of the things that I want to alert, all of you guys that are responding to calls is just the notion of silent hypoxemia. Most of our elderly, debilitated, at-risk patients really are not in a position to convey the full symptoms that they have to you. And they will often be what's called silently hypoxic, meaning you may look at them and they may not be tachypnic, they may not have necessarily an increased work of breathing, they may not have accessory muscle use, but yet when you throw the pulse ox probe on them, they're satting 82% on Romer, or 82% on their baseline 2 liters. So silent hypoxemia is well recognized as something that should be looked for, particularly in our elderly, more debilitated patients and our patients with comorbid conditions that are at risk for getting this disease. So the typical disease course, the incubation period is about 4 days. I usually give myself a high five in my mirror when I reach my 5th day off and I still feel good and I want to go outside for a walk with my family and I don't have a cough or a fever. So if you're good, if you're nearing the end of your 4 days off and you're feeling good, there's an excellent chance that you're still going to feel good through the beginning of your next trip. Dyspnea, shortness of breath, typically occurs about 6 days after you're exposed. Folks that require admission usually require admission around the 8th day of illness. And those that require ICU level care, which is again about 5 to 6% of patients that get hospitalized, typically occurs around the 10th day. Many of these patients get admitted to the general medical ward on nasal cannula. And then what we start to see is an escalating amount of oxygen that they require. And then those that do get sick usually have a very rapid fulminant course where they very quickly require more and more oxygen and wind up in the ICU, and many of these patients become intubated. How do we test nasopharyngeal swabs? I got to tell you, if it doesn't bring a tear to your eye, the nurse probably didn't do it right. That thing better be jammed back in the back of your nose and really get some boogers. The test is known as a PCR. The specificity is very high, meaning if it's negative, it's probably negative and you probably don't have the disease. The sensitivity of most of the PCR tests that are still out there, though, is not wonderful. It's on the order of 75%. Sensitivity means that a test will be positive when the disease is present. So some of the drive-through tents and places that are doing testing, the sensitivities of these PCR tests are still about 75%. So you're going to have some false negatives. That's why if you're still symptomatic or you think you're sick, or somebody says you may have COVID, but you test negative, it still is a good idea to put yourself in self-quarantine and kind of get through that incubation period and make sure you don't have symptoms. Some of the newer tests that are coming out, I can tell you from working at St. Joe's the past few days, our testing is a little bit different and becoming more widespread around the state and has a much higher sensitivity on the order of 95%. And I anticipate those tests will be more widely available. Just remember, a single negative test doesn't exclude the presence of COVID-19. If there's still a strong clinical suspicion, i.e. cough, fever, chest tightness, and GI symptoms, and you tested negative, just like you would in a normal situation, if you had those symptoms, you need to invoke what's called common sense. And you need to stay home, drink some water, some dilute Gatorade, keep yourself away from your loved ones, and nurse yourself back to health. You wouldn't come into work or go out in society if you had cough, fever, diarrhea. Again, a lot of what we're talking about with regard to mitigating this illness has to do with invoking common sense. So I'm going to hit the pause button for a quick sec, and then I want to move into talking about 2 to 3 patients that I've taken care of this past week. Sean, are there any specific questions or comments that have come up?
There's one question about if a young person with no cardiac or pulmonary risk factors has chest pain and shortness of breath, but no fever or cough, are they considered a PUI?
So our current definition of PUI is fever above 100.4 and upper respiratory symptoms. Like every case review I've done for the past 12 years that I've been involved in this department, I always talk about protocols being guides and not the 10 commandments. We still have to use, and I've said this many times on this conference, common sense. If you as a healthcare provider, if your spidey sense goes off and you say, you know what, this person may be sick, I may be missing something here. We have multiple mechanisms by which we can continue down the algorithm of treatment. Number one, we still have the ability of base station consultation available. Pick up the phone, discuss your case with a physician on the other end of the line. You can call one of us, the medical directors in the county. I think most of the you can call your supervisor, All of the supervisors have our phone numbers. You can err on the side of safety and transport the patient. So there are many ways to skin this cat. If a young patient has chest pain and shortness of breath and you cannot explain it, that patient probably needs to go to the hospital and get evaluated.
Do ARBs have the similar effect as ACE inhibitors?
Great question. I'm not sure anybody knows the answer yet. We are in general we are stopping angiotensin receptor blockers and ACE inhibitors in my ICU for a couple reasons. Number one is we are pretty sure that ACE inhibitors are a bad idea because of the upregulation of those receptors in the lung and the gut and a potential way for that virus to enter the bloodstream. We are stopping ARBs like irbesartan or candesartan, some of you guys are on those, because we just don't know. And then the other thing is that a lot of these patients, as they get sicker, get hypotensive. And the last thing we want is for their antihypertensives to still be floating in their system and have to be working against those as we start to provide kind of higher end supportive care.
So there are some other questions too. Again, I just want to reemphasize that, there are many kind of public health kind of information available via the CDC. We are certainly not here to over recommend what the CDC is saying and our healthcare public officials. So again, broad questions like if someone tests positive, what should the family members do as quarantine measures? We can address some, but again, I want to make sure that we keep this within context of the county.
Absolutely.
So there was a question about some counties have switched to an oral swab with saline sample capture because it's easier to do versus via drive-through. Is the nasal swab preferred?
Yeah, so the nasal swab is still the primary recommended testing modality. We do use oral swabs or the equivalent of oral swabs in some of our ICU patients. We will actually do what are called tracheal aspirates, where we kind of inject a saline bullet down the endotracheal tube, kind of swish it around and then suck it back up into a canister and test that. The ACE receptors are actually located in your mouth, in your oral mucosa, so it is not unreasonable to do a deep oral swab. And I haven't seen specific guidance about that locally, but it does sound completely reasonable.
A big concern is we're switching from cold and flu season to allergy season. Many coworkers have allergy symptoms, congestion, cough, sneeze. How do we rule out COVID?
That is a great question. And that's why we have widespread deployment of thermometers, and we're doing well checks. Again, I showed you on one of the prior screens, one of the sentinel features of this illness, often in over 80% of patients, is fever. And that's why we look for fever. Cough is not uncommon in seasonal allergies, but generally it's more, kind of congestion, rhinorrhea, runny eyes, runny nose. I'm not asking anybody to become a clinician and try to, in a moment, distinguish between a seasonal allergy and a routine viral upper respiratory illness and COVID. I would encourage folks to continue to follow department policy regarding well checks. I would encourage folks that are in doubt to contact the infection control officer and go through those mechanisms. But I think that we in the fire department can do what the community is doing, which is keeping ourselves at a distance from each other, both in the station and outside of the station, using frequent hand hygiene, monitoring ourselves for symptoms, monitoring temperatures. But we also have an obligation to a mission to provide public health, to take care of the citizens we serve. And so we can't overreact and panic when we get seasonal allergies. We should probably start our Zyrtec now. We should probably start our Flonase now. The cherry blossoms have already bloomed. So again, I think we have to use common sense and follow department policy and particularly monitor temperatures.
That's great. And I think a similar response would be if a provider, for example, in the field tests positive for COVID, there's a well-established structure and infrastructure available through the county on how to report that, and then guidance in terms of your own safety as well as your family safety. So I think that should be handled well-established mechanism through the county. We're also starting to send out to get CEUs in the chat box. There's now a sign-in link where you can sign in and fill out your name, your MIMS number, your LOSAP to get CEUs. And then for the career departments and other stations where you have many providers watching one screen, volunteers, feel free to text me. The career department's Captain Stewart is organizing with you guys to make sure you get CEUs. Yep.
So I appreciate, Phil, your comment about the ARBs. That's a great question. I'm not sure we know the science just yet. Jack Ammerheim, I appreciate your concern about seasonal allergies. Life goes on. People are still going to get seasonal allergies. Start your Singularis, start your Flonase now, get ahead of the game. Jeff Coleman, the 1 in 4 false negatives, what my experience is anywhere that does drive-through testing, any patient I discharge from the ER where I've done a nasopharyngeal swab and run a PCR, is that our discharge instructions specifically say that even if you're notified and you're negative and you continue to have symptoms, you should continue to remain in self-quarantine and at a minimum social distance. So thank you all for the comments on there. I'm going to go ahead with talking about some of the patients we've seen recently in the hospital. So again, amongst hospitalized patients, I think 10 to 20 is the early experience. I think actually locally we're seeing more like 5 to 6% will require admission to the ICU. Of those, a fair amount will require intubation. And the mortality rate is highly, highly variable between reports coming from China, where the virus might have been more virulent, through Italy to Seattle, and now to here. I think that we are still in the process of compiling the epidemiologic data on this virus. This is one of the things I'm going to talk about later, and the silver lining of all this has just been the robust exchange of ideas and shared learning and shared information, much like this conference right now. I'm extremely grateful to work with Dr. Barinholtz. He's invited me and some of my colleagues to join conferences amongst folks in his division at Hopkins. And before I remembered the snipping function on my computer, I took a screenshot. This was from one of the conferences that I attended at Hopkins earlier last week. And this was the first 23 patients treated at Hopkins. Things that I've circled just to point out to you: mean duration of symptoms prior to presentation, people were sick for about 6.5 days. The mean age of patients was 57, so a little bit lower than that 65-year-old at-risk group. And again, the predominant symptoms align with what we are teaching, which is cough, shortness of breath, and fever. I'm going to talk to you specifically now about 2 patients that I took care of this past week. The first patient was admitted on, and there's no patient identification in here. If ever there's a picture of a patient room, which there will be, I've blacked out the patient's face. The first patient was admitted March 24th. He was a 56-year-old man. He had a history of well-controlled diabetes, coronary artery disease in the form of he really had never had an MI or a stent. He was just on a baby aspirin. He had well-controlled hypertension on an ACE inhibitor. He had reflux disease, and he had slightly high lipids, high cholesterol. He came in with a presentation of fever, cough, shortness of breath, was weak for about 1 week, which aligns with the prior slide that I showed you with the Hopkins experience of about a 6.5 to 7 day prodrome of symptoms. He had not traveled anywhere. He had had no contacts. He had been mostly at home with his family. When he came into the ED, he had a low-grade fever. He was not tachycardic. He was not tachypnic. He had a normal blood pressure. And he had, despite not being very old, he had that kind of silent hypoxemia that I referenced earlier. He was satting 87% on room air. I saw him with my own eyes. He was speaking in full sentences. He was not tachypnic. He had no accessory muscle use. We were able to have a very normal, pleasant conversation. And it was just the disconnect between his oxygen saturations, which intermittently flashed down to 80% as he talked to me, and then even came up to only about the mid-80s on the non-rebreather, was very, very unusual. He was put on a non-rebreather in the emergency department. A surgical mask, a plain surgical mask, was applied over the non-rebreather promptly to limit dispersion of the virus to those of us that were wearing PPE and in the room. And by the time he rolled up to the ICU just a few hours later, we could not maintain his oxygen saturations above the 70s, and we went ahead and electively intubated him. And I'll say something about this is that, there's been a lot of shared information. There's been a lot of kind of shifts in the pendulum of how we care for these patients. Do we aggressively intubate early? Do we let them sit on a nasal cannula or a high flow nasal cannula or non-invasive ventilation like CPAP or BiPAP? Initially, the teaching was intubate early, stay ahead of the game. Now it's kind of shifted back a little bit to maybe leave them on a high flow nasal cannula and don't rush to intubate them. The bottom line is this guy needed to be intubated. One of the things that hasn't changed in all of this is that, unlike you guys in EMS, sometimes in the hospital, we have the luxury of a little more observation under controlled circumstances. But what we try to avoid is rushing in to intubate somebody when they're in distress. We want to go in there when we can put on our full PPE, go in there. Here we've actually set up dedicated airway teams to go in and get these people intubated under very, very kind of unique protective circumstances. And we don't want to rush in there as they're kind of crashing and burning. So one of the things that I want to share with you, and I'm still frustrated with, is that even an ICU patient who's profoundly ill and intubated, I admitted him on the 24th. I didn't get his positive test back until the 28th. Every day that goes by, the turnaround time in testing is getting better, but it's not wonderful. And it's very variable by where you work, what region of the state you work in, what facility you work in. But I would argue that it doesn't even matter for me. If I see this syndrome that looks like COVID-19, I begin treating it. And when I get the confirmatory, and I wear my PPE regardless. And when I get the confirmatory test back, I go, yep, that's what it was. So in the critical care side of things, which is what you guys do in EMS often, it doesn't really even matter what their test result is immediately. You still have to put on your PPE, you still have to assume that they have the disease, and you still have to support them and treat them as such. So, things that we've learned from shared information trickling from China to Seattle to now the East Coast is what this patient had. He had a normal white blood cell count. Typically, in both viral and bacterial illnesses, white blood cell counts go up. They're a marker of inflammation and infection. He had a normal white blood cell count. He had a low sodium, which is very common in people with severe respiratory illness. And he probably also had a low sodium because he wasn't really eating and drinking as much as he should have been in the 6 or 7 days that he was ill before he presented. We often will measure other surrogate markers of inflammation to help us rule in or rule out COVID early in the illness. And I'm not going to get into a deep conversation about this, but you should know that they're called ferritin, C-reactive protein, lactate dehydrogenase, LDH, and then liver function tests like AST and ALT. Oftentimes, all of those are elevated in patients that have COVID, and we see those things, those inflammatory markers elevated well before we see the patient have a positive test result for COVID. Many of these patients also have a little bit of kidney dysfunction, and oftentimes these patients will also have what looks like mild rhabdomyolysis, elevation in their muscle enzymes, something called CPK, which is also just a very interesting kind of red flag that goes up and makes you think about COVID. So he, like most of the patients I've treated, has had an X-ray or a CAT scan that shows bilateral patchy infiltrates. So normal lungs are nice and black, air is black on an X-ray or a CAT scan. All this kind of white schmutz, those are all patchy infiltrates, bilateral pneumonia. One of the things that I think all our paramedics should be aware of is that we're not only going to be taking care of PUIs or maybe even people that have gone through drive-through testing and have gotten either positive or negative test results, but we may start to see more and more patients being prescribed medications like hydroxychloroquine, also known as Plaquenil. And there's two things that especially our ALS providers should know about, and that is hydroxychloroquine can be a pretty cardiotoxic medication. It can prolong the QT interval. One of the things that we're seeing pretty regularly now is that amongst the folks that get critically ill, a fair amount of those patients, as they start to recover from the respiratory side of COVID, are developing a viral cardiomyopathy. So there may be a subset of patients that are still in the community, that are quarantining at home, that may or may not have been prescribed hydroxychloroquine, aka Plaquenil, that may present with QT prolongation, dysrhythmias because of QT prolongations like torsades, or a cardiomyopathy. Okay, so remember, cardiomyopathies, weakening of the heart, can occur in a lot of other viruses, Coxsackie virus, other more mundane coronaviruses, where the heart becomes weak as a product of the viral illness. We are seeing this late in the illness. So you might start seeing patients that present with CHF symptoms a week or so after they've been diagnosed with coronavirus. Or if they were home and they never got tested, they may present with CHF symptoms. So I just want to put that on your radar, that as ALS providers, when we do run 12 lead EKGs, we might want to ask, hey, were you on or prescribed hydroxychloroquine, Plaquenil? Take a look at the EKG, see if their QT is prolonged, particularly if they're having any sort of transient or sustained cardiac dysrhythmias. So getting back to my patient, again, young guy, a couple comorbid, well-controlled comorbid conditions. He very, very quickly became profoundly hypoxic. And what I'm showing on the screen are serial blood gas measurements. Most of these patients, within the first hour or two of taking care of them, we put in central lines because of the amount of infusions they need. We put in arterial lines to measure frequent blood gases and monitor their blood pressure quickly. And what you'll see if you look at the PO2, it's just marching down from 125 to 81 to 63. And this patient is on a magnificently high level of PEEP. He's on 18 of PEEP. And just as a reminder, right now in Baltimore County, when we do BVM ventilation, or we ventilate through an endotracheal tube, we are currently not using PEEP. We may one day soon have PEEP valves where we can maybe put on 5 or 10 of PEEP. This patient was on 18 of PEEP. He was on very high fraction of inspired oxygen, 60%, and I could only get his PO2, the oxygen in his bloodstream, up to 63. The bare bones to keep somebody alive is keeping a PO2 above 60. And then one of the things that we did as he was becoming more and more hypoxic is we put him in a prone face down position. And I'm going to go to the next slide, but what you'll notice is when we proned him and moved him from supine to face down prone, his PO2 in his bloodstream shot up from 87 to 128, much, much better, despite no changes in the percent of oxygen that he was on and the amount of PEEP that he was on. And I'm going to show you why that happens. And it goes back to that a lot of these patients are getting ARDS that are critically ill. There are two general buckets of ARDS, and we see both in EMS. There's what's called pulmonary ARDS and non-pulmonary ARDS. Pulmonary ARDS is lung damage that occurs from a pulmonary infection like COVID-19 or a regular bacterial pneumonia or an aspiration pneumonia. Non-pulmonary ARDS, if you spent any time at shock trauma, is seen in a lot of people that have polytrauma, that are in motor vehicle crashes. It's seen in people that have pancreatitis, either due to alcohol, gallstones, or from traumatic injury to the pancreas. So there's two kind of big buckets of ARDS. And of course, the ARDS associated with COVID-19 is a pulmonary form of ARDS. It generally develops within 1 week of the inciting insult, the virus. People get hypoxic respiratory failure. They get those bilateral infiltrates that I talked about in their lungs, and then it's categorized as mild, moderate, and severe based on how impaired their oxygen is. This is a typical CAT scan of somebody with ARDS, and what you'll notice is that there are kind of three zones on this CAT scan. The bed is the green line at the bottom. They're lying flat in bed. When you look at a CAT scan, you got to imagine the person's feet coming towards you and their head going away from you. The bottom of the lung, which is kind of most compressed, is the most severely affected. The middle of the lung is moderately affected, and the top of the lung, those nice black areas, are actually relatively normal looking lung. But where does blood flow go when you, healthy folks on this call, or my folks in the ICU, or your patients in the back of a medic unit lying supine, where does the majority of blood flow go? Well, the majority of blood flow follows gravity. Blood tends to go to the bottom or most dependent portion of the lung. And why is that problematic? If most of the blood flow goes to the most diseased portion of the lung, then you get what's called shunt. You get blood flowing through that region. It's so filled with crap and congestion that it never sees oxygen, and then it gets pumped back to the heart and out to the body. So that's a problem, is this shunt physiology that we see. So what do we do to fix this? We flip people upside down like a pancake, and we put them face down. And when you do that, you immediately see this rise in their oxygen saturations. It is on the order of seconds, literally, if the tube doesn't become disconnected when you do that. So you flip them upside down, you put them face down, the oxygen saturations will shoot up from the 80s to 100%. The PO2 on a blood gas will shoot up, as in my patient, from 60s to 120s. And you've suddenly fixed the patient by diverting blood flow. Blood flow still follows gravity. We didn't become weightless on Earth. Blood flow still goes down to the bottom, but now the bottom is the patient face down, and the front of their chest is against the bed and their back is towards you. And one of the things that when we do this is we have to just be meticulously careful about the same things that you guys have to be careful about. Accidental disconnection of an endotracheal tube from a BVM and aerosolization of virus unnecessarily. Again, everything that you do in EMS aligns completely with what we do in the hospital, and most of it revolves around attention to detail and pumping the brakes. So this is the before and after. This is that guy laying face up and then face down in the prone position. And now we are pushing the majority of blood flow to the relatively non-diseased portion of the lung. And again, when we checked a blood gas after, his PO2 shot up from 87 to 128, despite us not changing his ventilator settings. These are pictures of the two patients that I recently cared for as recently as yesterday in our ICU. The patient on the left is the patient in this vignette that I'm talking about right now. He is in prone position. He is face down. We put our EKG leads on his back. We protect his face in a donut. We run the ET tube and the OG tube and all his lines kind of through that protective donut, and he's attached to the ventilator. And we do this manually. There are machines that you can actually, beds you can put people in that will automatically prone them. But the quicker and more efficient way to do this, especially when you have a patient, a surge patient population, more patients that need to be prone, is going in with a team of people. And we refer to it as our prone strike team. We go in there, and it's usually 4 to 5 people, mostly nurses, a respiratory therapist to guard the endotracheal tube with their life. usually sometimes a physician providing oversight to make sure that the patient remains hemodynamically stable. And we can usually prone people within 3 to 5 minutes safely. One of the very interesting things that we're doing is, if you look at the right side of the screen, is we've started proning people that are not mechanically ventilated, that are not intubated. This is a woman also in her 50s that I'm taking care of right now that has COVID. She's actually DNR-DNI. She is on non-invasive ventilation. It's a little hard to see in that picture. And we have started proning these patients as well. And it's something we can do pretty easily. We are also, when we go down to the floor, the medical wards, and we're seeing patients that are on 2 liters, 4 liters, 10 liters nasal cannula, we're having those patients self-prone and spend some time sleeping face down, or even rotating left and right on their side. So, self-proning is something that's emerging as a strategy to help take care of these patients. Wouldn't we all like to get that back rub in the picture with rose petals and incense and the little lute playing in the background? We're not designed to be supine. We, especially in the fire service, we're designed to be up and moving. And as humans, we're designed to be up and moving. We're not designed to be laying flat on our back. And what's really interesting is that the teaching that we did before this epidemic started about flat ain't fat and that we should not be intubating patients flat on their back really aligns with some of this stuff, is that supine positioning is not the way to go. That when you are supine, you get atelectasis, you get lung collapse, you get pooling of secretions, and that when you go prone, you can actually increase the amount of spaces in the lungs that are open, you can aid clearance of secretions, and you can limit the amount of shunting. Couple of just basic principles that we use to take care of the patient is, we put people on low tidal volumes, we let their CO2 rise. A high CO2 in the lung can actually reduce the amount of inflammatory mediators in the lung. We prone these patients early. Some centers prone people for 16 hours. Other centers keep people in the prone position for up to 48 hours. It's very important that when you flip the patients back over, you look for facial swelling, that if you're considering extubation, you actually sometimes deflate the cuff to see if there's an air leak around the endotracheal tube so as to not take the tube out and have their airway swollen. We avoid giving them a lot of fluids in general when people have ARDS, dry lungs, or happy lungs. And we sometimes use diuretics to keep people on the negative side of fluid balance. Most of these patients require a significant amount of sedation. Some require continuous infusion of paralysis medications. Many require medications like norepinephrine or phenylephrine or epinephrine in a continuous infusion to keep their blood pressure up. And what we've learned is that we should not be rushing to extubate these patients. They often need intubation 10, 7, 10, maybe even 14 days. And that when we rush to extubation, we are seeing a fair amount of people develop this later stage heart failure.
Hey,
so,
Dave.
Yeah, go ahead, Sean.
So a couple of questions. So why are patients presenting with a low SAT, but yet clear lung sounds? This is kind of around the time that you were talking about presentation. And then the follow-up question to that, or a link question, is if the patients look so much better, but their SATs are bad, should we be pushing regarding treatment of the patient versus the equipment, i.e. the oxygen SAT?
All right, so let me back up to the first one. The concept of silent hypoxemia in a patient with a low SAT that is not in visible distress is not uncommon, even in the absence of COVID, but we're recognizing it more as a red flag. A patient, particularly if they're younger and they're not as debilitated as some of the folks that we pick up at nursing homes, may tolerate a low O2 SAT. What we'll often see, though, when we check a blood gas is that they are actually, even though they don't look visibly tachypnic and we don't see visible accessory muscle use, they are breathing a little bit faster. Their CO2 may be down a little bit. Their PO2 is certainly down. I don't have a great explanation for why they look so damn good, but it's important to recognize that it is possible, if you're otherwise healthy or relatively healthy, to have a low oxygen saturation and not be struggling, period. As far as equipment, if you see a low SAT and you have a good correlation with your heart rate, trust it. So I often look at, when I put a SAT probe on somebody, if I'm not sure about the waveform, if I'm out in the field with you guys and it's cold, I see if there's alignment between the heart rate on the oxygen saturation probe and the cardiac monitor, or simply checking their pulse. And if there's good alignment, that's their oxygen SAT. So, I'm going to fly a little bit through some more slides. These patients are on many infusions. They're on very kind of complicated ventilator settings, and peripheral IVs are often completely inadequate once they get this critically ill. They need triple or multi-lumen catheters. They need arterial lines. We have a very strict protocol by which we are governed on who to give hydroxychloroquine to. It seems to be organization by organization dependent. Many organizations have a very strict set of criteria regarding who gets hydroxychloroquine for many reasons. The supply is not totally robust yet. It is a cardiotoxic medication. It has questionable benefit. It has not been studied in randomized controlled trials for this outbreak, for this disease. So I think the guidance and restrictions on hydroxychloroquine are good. And I'll share with you kind of what my institution's looks like. So this patient, just to kind of finish up his summary, we put him on hydroxychloroquine, we held his ACE inhibitor, we did very aggressive critical care, we kept him prone for many days. He developed multi-organ failure. We had, sadly, one of the situations that we're dealing with is the inability to have face-to-face meetings with families or even visitors for these patients. We had many virtual meetings through Zoom with his siblings and his parents. And unfortunately, 12 days into his illness, he did die. I want to share with you something maybe a little bit more uplifting. We did have one of the first patients that I was aware of that EMS, Baltimore County EMS transported, was a 33-year-old man who used heroin, fentanyl, and cocaine. He came in on the 22nd after a heroin and fentanyl OD. EMS gave him intranasal Narcan, and he left the ER AMA. He had blood work drawn, and his blood work that resulted after he had left AMA. The blood work was pertinent for high CPK, which is the muscle enzyme that goes up when you have rhabdomyolysis. His creatinine was a bit elevated, and they actually called him, and he picked up the phone amazingly, and they said, "You should probably come back. It looks like you have rhabdo. Your creatinine is elevated. We need to fix you up." And what did he do? He called 911, and he was transported by our EMS providers, who were wearing appropriate PPE. And he came back and his vital signs are shown there. He was a little tachycardic. He was 92% on room air, which is not normal for an otherwise okay-ish 33-year-old man. And by later that night, he was in my ICU. His sats were 70 to 80%, despite being on 15 liters nasal cannula. I tried to temporize him. I put him on something called a vapotherm, also known as Optiflow. He kept desatting. And by the following morning, as I was finishing up my night, he was intubated for hypoxemic respiratory failure. I was treating him both. I didn't know what was going on. He had infiltrates in both of his lungs. I said maybe this was due to the heroin overdose, which we can see when people are overdosing on opioids, particularly when they've been snoring and obstructing their airway, particularly when they've gotten multiple doses of IN, intranasal Narcan, from the police and EMS. So I was treating him for non-cardiogenic pulmonary edema related to that. I thought he might have COVID. He also had what looked like rhabdomyolysis. And I sent off all my usual testing, including my SARS-CoV-2 COVID-19 test. I sent all the inflammatory markers that I use to kind of risk stratify whether or not people have COVID, and they were all elevated. And long story short, he was intubated on the 23rd. I extubated him on the 27th. I sent him to the floor the next day when I weaned him down to a few liters nasal cannula. And on the 8th day of hospitalization, on room air, satting 100%, he went home. So, if you get these patients to care and we provide appropriate care for them, even if they do naughty things like use heroin and fentanyl and cocaine and have made their body a bit more debilitated than maybe it needs to be at the age of 33, they can still fare well. And I would think that if some of us are in fire service, not using cocaine, fentanyl, or heroin, which I highly recommend, we too could have this course if we were to become critically ill. One of the things that I learned from this gentleman is that the most dangerous portion of his care was extubation. So unfortunately, this video doesn't work and it doesn't matter. What I realized is that intubating these patients is actually the lower risk thing. In my world where I can give an induction agent and paralyze people and they don't sputter at me and they're motionless, I can get an ET tube in 10 seconds. The dangerous side of the equation is when we go to extubate patients and they sputter and cough. And in this case, this patient just decided to look me in the eyes with my full PPE on and just projectile vomit on me. And that's where I got a little bit of a pitter patter. I said, "Oh, damn, wow, that was heavy. I really didn't want that to happen." But again, I put on my PPE correctly and I got on with my life and I doffed my PPE correctly and I washed my hands and I used alcohol-based hand rub. And I was very, very attentive to not be distracted when I came out of the room. And I made sure when I was taking off my N95 that I had used alcohol-based hand rub first. And you know what? Fast forward to right now, I'm still alive and I'm still healthy. So this was a COVID-19 positive patient, a pretty profound exposure. But while I was wearing my proper PPE, and at the end of the day, I'm happy to still be talking to all of you. Again, I'm not going to get into the meat and potatoes on the slide, but we have very restrictive guidance on who to give hydroxychloroquine to. I'm going to kind of move forward just in the interest of time. I want to talk on the last few slides about how we deal with change and uncertainty in this evolving crisis and how we overcome anxiety. I'm going to talk to you about some of the challenges that I faced in the past month taking care of these patients and getting prepped up to take care of these patients. The biggest thing, like many of you are concerned about, is limiting exposure. And we have to adapt the way we work and our workflow and things we wear and what we touch and how close we are with our brothers and sisters. And we have to limit exposure to each other and to our patients. One of the really cool ways that we've done this, and probably many of you have seen this in social media, but this is actually a picture of a patient I'm taking care of right now, is we run massive lengths of extension tubing from the patient, their central lines, out through the fuzzy crack in the door to our pumps in the hallway. If a patient is on a frequently titrated infusion, we preferentially put those pumps in the hallway so that our nurses don't have to go in and out of the room constantly to titrate infusions. Communications through thick glass doors in rooms that have constantly running very loud HEPA filters is virtually impossible. How did we get over this? This is just, MacGyvering things, thinking about things kind of coming together and collaborating. So we realized that we could use dry erase markers on our glass. They wiped off easily. We got whiteboards both inside and outside the room to kind of show each other. And this past week, we bought Starbucks style walkie-talkies. So now we can order lattes and tell each other when we run out of fentanyl. Equipment modification, we don't put people on our regular BiPAP machines anymore. We run all of our patients on non-invasive ventilation through ventilators. When people are on typical BiPAP CPAP machines, there's usually a passive exhalation valve over the nose or near the chin that allows for dispersion of particles from their face. If we have a critically ill symptomatic patient, we attach those patients to our ventilator. It is a completely sealed mask, very different than the typical mask that's used in the community. We put a viral filter both on endotracheal tubes and non-invasive masks near the inspiratory limb on the patient. And we also put a viral filter as the expiratory air is returned to the ventilator. PPE initially, I think the biggest stressor in this epidemic has been both in the fire service and in the hospital. What PPE do I wear? When do I wear it? How do I store it? Who's giving it to me? Am I going to have enough? And you know what? It takes a little time to get it right, but you're eventually going to get there, and I think we're there now. We, on the left, have a picture of how we initially stored our PPE, and it was a hot mess. We had little sandwich baggies with our names on them. We put them in little pink basins that were labeled with letters of the alphabet, and it just quickly became apparent that it was a mess. And shortly thereafter, we devised a nice, very neat system. We took whiteboards, deployed them throughout the hospital, put hooks on them. Now we have big bags. We keep our masks in the bag and our face shields on the outside, and we innovated, and we solved the problem. We innovated on the fly. We typically, don't prone people that are not intubated, but we do now. And you know what? We do it a lot now. And it's been very cool to be part of taking care of these patients and, again, sharing information and learning from each other, and just kind of the collaboration and the uniform mission of doing a good job. And we innovate on the fly. And every day we learn a little bit better how to do things, and we share that information. And while that can be stressful for some people, that there's a constant flood of new information, that's the way it goes. That's how these things work. This is not called the novel virus for random reasons. It is novel. And the way we're treating these people and the way we're protecting ourselves evolves every day. And our leaders and our incident commanders synthesize information and share best practice with all of us. One of the things that I think has made us all anxious, as I look out my window, my surgical ICU is located on the top floor above this tent set up in the parking lot. I finish rounds, I take care of my patients, and I look out and I'm reminded, I see that tent, and I say, when will the dam break? And then I learn not to turn on CNN or Fox when I go home, but then you see something like this come up on your phone, or when you get home, or when you're in the break room, and all of this stuff can be very anxiety provoking. The anticipation of, when are we going to have to invoke the pandemic triage protocol? When am I going to get to the point where I'm going to have to do allocation of scarce resources? And, in the beginning of this and to this day, I remember very clearly in the first few weeks of March, I was looking forward to taking off a few days, going to the Guinness Brewery and having a beer with one of my buddies. And that's right when all of this started to happen. And where was I on St. Patrick's Day? Right here with my colleagues from the emergency department, going through drills, learning how to intubate in full PPE, learning how to intubate with video laryngoscopes under plastic drapes, learning how to extubate into plastic bags. And the pace of preparation was furious. I think it's settled down a little bit, but I would argue that much like what you're doing in the EMS realm with the command center, we continue to do in the hospital is that in between every single patient and every single call, we continue to look at the better way to do things, and we reinvent and we innovate and we share information. There's also constantly changing information, and I know that's been very stressful for both people inside and outside the hospital. This is on the right side of the screen is one of the first things that came out on social media about do's and don'ts of intubation. And you'll look at the upper right and it says, don't use high flow oxygen, including BiPAP, CPAP, high flow nasal cannula, and that we should intubate these patients right away when they get hypoxic. In the last week or two, the pendulum has shifted way, way back in the other direction. That yes, there are going to be a fair amount of patients that get very sick that will need to be intubated, and they should be intubated early, and we should avoid having to rush into their room without actually having proper protection on. But that there are a fair amount of patients that will do quite well with just a high flow nasal cannula. So information is constantly changing. And when you add all of that up, it produces anxiety. The week before we started to see the 5 or 6 patients in our current ICU that had COVID, I was in our simulation center teaching everybody how to do donning and doffing and use a safety officer for donning and doffing. And I was stressed. I was highly caffeinated, but I really felt good. I felt a sense of purpose and mission. I felt like I felt embraced by my organization, that I was doing important work. I felt a greater service, greater sense of mission and service to the community. And then I loved being part of the preparatory efforts. And then I realized that, Friday was there. I kind of went home and decompressed over the weekend. And then I said, oh my God, I go back to rounding the ICU on Monday for 7 days, and I'm going to have to intubate these people. And I got to tell you that I don't hyperventilate, my heart rate doesn't go up, but I started to think a little bit. It reminded me of when I first came to Maryland in 2001 to do my residency, and my first rotation was on an infectious disease service on the top floor of the University of Maryland, taking care of a ward of 30 patients, not with HIV, but with AIDS that were profoundly immunosuppressed, and I was putting in IVs and drawing blood, and I had never had that coming from Syracuse, New York, where I went to med school. And my heart went pitter patter, and I said, man, I better be careful. I better pump the brakes and protect myself. But you know what? I have a mission, and I'm going to get this done. I went through the same thing when we were preparing a few years ago for potentially receiving Ebola patients, and we set up a biocontainment ward. And I said, man, they're like, unlike this picture, there better not be a breach between the top of my PPE and my neck. And I better put on my PPE right. And, when those patients come, they're relying on me and my ICU team to take care of them. So, you know what? I'm going to put my head down and I'm going to be prepared. And I'm going to learn and I'm going to practice and I'm going to rehearse. I went through the same exact emotional state when I walked in the door Monday morning to start rounds after all this preparation. And you know what I said? I said, good. And for those of you that don't know Jocko, you shouldn't be a firefighter, EMT, or paramedic. You should know Jocko. You should watch this video. You should watch it before you go into every shift to get pumped up. I'm not going to play the YouTube clip, but basically Jocko, former Navy SEAL podcaster, he talks about adversity, and he talks about not getting the equipment he needs. He talks about different information coming out from commanders than maybe what he's hearing on social media. And you know what he says? He says, good, bring it. I'm going to learn from this. I'm going to refine my approach to how I navigate through life, how I take care of things that I need to take care of, and I'm going to come out stronger for it. And I embrace that attitude. You have to have a positive attitude. You have to say, in light of this, man, what a privilege to be on the front lines while everybody else is locked in their house. I get to see history. I get to be a part of history. I get to be a part of shared learning. I get to share best practice. I get to be a part of this collaborative where we share information, not at conferences talking about esoteric diseases, but in real time. Good, bring it. I want to be part of this. And that's my philosophy. So good, I know how to limit my exposures. I now know how to communicate through closed doors. I know how to put on my PPE. I trust my PPE. I trust the information that my colleagues share with me. I adopt best practice and I say, good, let's do it again tomorrow. So I want to pause here. I know it is 11:09, but I probably have about 15 to 20 minutes worth more of material. I wanted to give everybody a little bit of insight into how we do triage in the hospital, but I want to hit the pause button and just see, Sean, if you had any comments or questions.
No, I don't see any additional questions.
Great. I'll try to wrap it up then in the next 10 to 15 minutes. I want to give everybody
super fast though. Just check the chat for those who need CEUs. The links have been sent out. One link if you're an individual, another link if you are a group of people watching on one device. Thanks.
So Michelle, the last patient that I presented was indeed positive for COVID. He's the one that did naughty things, but yet had a very good quick ICU course and turned around and was discharged home. So getting into kind of how we do triage in the hospital, you know, I got to tell you that I've kind of been smiling at a lot of the meetings that I'm going to in the hospital, both in person with folks and virtually, because what the hospitals are getting geared up to do now is something that we do exquisitely well in EMS and the fire service, and that is utilization of the incident command structure, utilization of best practice for mass casualty incidents, triaging patients. And I always walk into these meetings and I go, man, we need some of our officers from the Baltimore County Fire Department in this meeting to just tell people how it's done. But you know, that represents yet another thing that I'm very proud of, is that in EMS, we often do things that the hospital sees and goes, man, that is a better way to do it. We were using IOs well before hospital rapid response teams and code teams were using IOs. And now guess what? There's IOs in every rapid response bag. We were using video laryngoscopy in the field before hospitals. A lot of regional hospitals were using glide scopes in the ERs and ICUs, and you know what? They're all over the place in the hospital now. High performance CPR is something we do much, much better in our fire department paramilitary hierarchical structure, where we walk into a code and there's pretty much quiet and everybody knows what their role is, and we know who's in charge and the different layers of command and who's going to kind of dish out the instructions and make things work seamlessly. The incident command system, MCI triage, these are all things that we do very, very well, that now hospitals are saying, man, we've got to catch up and do it as well as our EMS fire department personnel. So we're lucky in the United States that we actually have the most number of ICU beds per capita. The data in Maryland, I'm going to share with you a little bit. You know, these are the number of acute care beds in hospitals. Now, it's important to note that acute care beds are not just ICU beds, they're everything. They're all of the beds in the hospital. They're your psych beds, they're your OB beds, they're your tele beds. Baltimore City has about 3,600 beds. The county has about 1,000. In Central Maryland, if you put all the counties in Central Maryland together, there's about 5,900 acute care beds. And in Maryland total, there's about 9,400 beds, which if you look at the bar graph on the left, there's been a bit of a contraction since 2010, when we were over 10,800 beds. And with that, the inpatient population, average census in hospitals, has also gone down. But just keep that 9,400 number in mind. So if you look at the latest census data from the state of Maryland, we have about 6 million folks in the state of Maryland. And according to the last bit of census data, there's about 15% that are over the age of 65. And if you take every acute care hospital bed and fill it, you could only accommodate about 1% of our citizens over the age of 65. And I think that's where most of us in the hospitals get nervous. Not only do we see a potential strain on resources with regard to all of our hospital beds, but we see a potential strain with regard to certainly our ICU higher level beds. What we've learned from looking at the awesome, Maryland Department of Health dashboard is that the average age of this disease continues to tick down a bit. There are a fair amount of people in their 20s and 30s with no comorbid conditions getting this disease. We have a fair amount of disease in Baltimore County. There's more in Montgomery and PG County. Again, if you think about the way things break down, about 80% of people have mild illness, 14% or so need hospitalization, and of those hospitalized, maybe about 5 to 6 require ICU level care. And if you look at if you just look at what the potential ICU need would be, 6% of 3125 is only 187, and we have way beyond 187 ICU beds in the state of Maryland. If you just look at those that are hospitalized, 6% of 821 is 49 patients. Again, what I want people to know right now is, although we're seeing higher acuity and slightly higher volume in our hospitals, particularly in the ICUs, that we are still operating in a system that can accommodate and care for those patients safely. Looking specifically at ICU beds, this is data from fiscal year 2018. There's about 1,200 ICU beds scattered across the state of Maryland. But what's important to know is whether that number is 1,200 or 1,400, and it has gone up a little bit since this last accumulation of data, is that some of these beds are intermediate care beds. They're not truly ICU beds. That even before this, we did have a shortage of intensivists and critical care nurses. So there's many other factors to just the mere number of beds that we might need if we saw a growth in the amount of patients that were critically ill. We do triage well. We know how to use START. We know how to use Jumpstart. We know how to lay down the tarps. We've got SORT 50. We've got command officers that know how to put up incident command structures and triage structures very, very well. A little bit about kind of extended triage that folks should know about is that primary triage. It's done in the field by all of you using the mechanisms that we already know well, Jumpstart and START. Secondary triage is typically done once patients get delivered to a field hospital or a traditional hospital. It's typically done by a healthcare provider like a physician or CRNA or somebody like that. And it's always done after initial life-sustaining interventions, control of hemorrhage, mitigation of an obstructed airway, things that we do in EMS. Tertiary triage is what we then do in the hospital on the inside. And I want to talk a little bit about that right now. So there's a document that was created during the H1N1 swine flu epidemic that taught us or gave us guidance as to how to do triage in the hospital. And this is the face sheet of that document. And it was the result of a 5-year multi-institutional collaborative effort that also engaged members of multiple community forums as to how to triage scarce resources in the hospital. What are scarce resources? They're a little different in the hospital than I think in the field. They're ventilators is the thing that comes to everybody's mind immediately. Oxygen, how many oxygen manifolds do you have? Dialysis, that's actually a biggie. How many rooms do we have where we can do dialysis? How many nurses that do we have that are functional that can do dialysis? Blood products are in scarcer supply right now. Can we do surgery right now? Can we do things like bypass, put people on ECMO? Critical care, are there enough intensivists and nurses to work in ICU units? Are there simply enough healthcare providers to man the hospitals and the general medical wards? Certain drugs and IV fluids, is there enough hydroxychloroquine should we decide to use that? And then in our realm, is there enough transport units? I was very, very grateful to see when I read one of the latest situational reports put out by our command staff of the reserve units being positioned at the FRA for our recruits to use. So should we see a surge in call volume? There were 5 things that kind of emerged. There were 6 principles that we used to guide discussion when these principles of allocating scarce resources came up. Things that were discussed were, should it be first come, first served? Should there be a lottery system? Should we talk about prognosis when we decide who gets what in the hospital? Should we talk about life cycle? Should we talk about what decade of life you're in, whether or not you're going to get a ventilator? And what value you as a firefighter, EMS officer, EMT, paramedic, do you get more value than the same person next to you? These are all questions that were raised to communities and community forums where they talked about how to do allocation of scarce resources. And I'm going to fly through these last few slides, but the key thing is the community wanted transparency. They want to know, how are we going to do this? They said, why can't you just solve the problem? Why can't you go to a 3D printer and print some ventilators? And they encouraged us to be innovative and think about ways to put multiple people on a single ventilator. They said maybe we can use a combination of principles to guide who gets a certain scarce resource. They wanted excellent planning and coordination and communication, much the way you see being done right now from our Baltimore County Fire Department Command and Control Center, and much the way we've stood up a command center in the hospital. They wanted to know, community members, when these guidelines were being formed, they wanted to know, what happens to people that don't get ventilators? How are we going to compassionately treat them? They wanted to make sure that there was as little bias as possible when we invoke these triage tools. They wanted equity. They did not want preferential treatment. They did not want a donor to call 911 that donated a medic unit to a volunteer fire company to get treated any differently with the pandemic triage protocol than the same person of a lower socioeconomic status in a different house or a different part of the county. In the hospital, they do not want biased treatment, preferential treatment for donors. They want equal treatment and equity across the board. They wanted to talk about the system for analyzing patients that were already on ventilators, and when do we consider withdrawing care, and how do we do that, and how do we reallocate ventilators that are already in use. And they wanted support for people that have to make these emotionally wrenching decisions. So how do we do this? I'm going to kind of skip a slide, but the bottom line is, in the hospital, we've done much of what we've done in the field for years. We've created a triage officer. We've created a supportive team known as the triage team. We've come up with criteria for allocation of scarce resources, and we've come up with a scheme for reassessing people that are already given scarce resources like a ventilator, like dialysis, like oxygen, and so forth. In our organization, every organization might implement the state's guidelines a bit differently, but this is what we have. We have an officer. We have a supportive team that helps the officer. We have a mechanism that we use where we assess these patients using both electronic data and face-to-face bedside data. We have a process by which we communicate our decisions to patients and families, much the way that we've been instructed by Dr. Wendell to instruct patients when, if and when we invoke the pandemic triage protocol of explaining why a patient may or may not be transported to the hospital. We can't just do these things and walk away. A little different than kind of walking through the crashed airplane or bus on 95. We will often have the luxury of talking to patients and families in situations like this. We have an appeals process built in for patients and families. We do front and back end triage, which is very, very similar to what we do in the field. We front end triage, where we look at ventilator versus no ventilator, and then we do continual reassessment, much the way we would do if we were in like a tech scenario, operating in a hot zone, getting to a casualty collection point, doing some life-saving interventions, determining if the patient is to be resuscitated or not, getting them out to a warm zone, into an area where we can do more elaborate treatment, reassessment, perhaps re-triage, much the same in the hospital. We'll do triage on the back end as well. And then there's oversight. We communicate our triage decisions up to the state, and then the state communicates back down to us what resources are available at other facilities. The point system, if anybody's interested, that is recommended by the state is something called, it's actually on the screen here, and we use something called the SOFA score, Sequential Organ Failure Assessment. I'm not going to get into the depths of how this works, but we look at a lot of physiologic data. We look at data from a blood gas. We look at data from different organ systems in the body. And the sicker you are, the higher the SOFA score that you will be assigned. And then we also screen for whether a patient has other serious comorbid illnesses like metastatic cancer, horrible COPD. And then we also consider where they are in the life cycle, what their age is. And then there's an assignment of points. And based on those points, and we're trying to do this as objectively as possible, patients are coded red, orange, or yellow. And I'll show you what that looks like in a second. These are examples of major comorbid conditions that we consider when we assign priorities. Examples of major comorbidities: advanced dementia, metastatic cancer, horrible COPD, end-stage renal disease, heart failure. This is a screen just this past week. We kind of finalized the development of the workflow for our hospital. We built a triage note that our 15 designated triage officers will use. It incorporates the SOFA score. It also incorporates something called the Charlson score, which basically categorizes how many comorbid conditions a patient has. And then we also use something called the Clinical Deterioration Index, which is a form of artificial intelligence that sniffs through hundreds of data points in the patient's chart from the moment they come into the ED and are hooked up to the monitor, and we start gathering information that gives us some predictive analytics about whether or not a patient is likely or not to decompensate. And then with that data, we go to the bedside, we do an assessment, and we have this data automatically imported on the order of seconds into a note, and we write a note and we explain our logic in that note, and then we assign a patient a triage category, highest priority for an ICU resource red, intermediate orange, and then low priority yellow. And you'll notice that this aligns very nicely with our traditional triage colors in the field. The only difference being is that kind of intermediary orange category that we will be using in the hospital. It's important to note too that when we do invoke disaster standards of care, which we are currently not operating under, we're operating under a contingency right now, that there are certain patients that we just don't allocate resources to, and those include common sense things, as would be seen in a mass casualty incident. Cardiac arrest patients, patients with irrecoverable neurological damages, and then burn patients with greater than 50% body surface area. This is again when a formal disaster is declared, both in an individual organization or on a state level, we would begin to follow those things. The information with regard to the way that we triage in the hospital is necessarily communicated up to a central triage committee in the state. And then again, in a bi-directional fashion, you see those arrows going both ways. The central triage committee lets us know about the current state of the pandemic, available resources, ventilators, dialysis units available throughout the state, so that when we go to the bedside for patient X, Y, or Z, we not only know what's available at our individual organization, but we also know what other resources might be available regionally. One of the questions that's come up as we've gone through kind of modeling and rehearsing and practicing hospital triage is, do healthcare providers get kind of a weighted assessment? And this is actually a very controversial area. It gets down really into some pretty deep, heavy ethical conversation. But there is guidance in the document that specifies that individuals who perform tasks and are vital to public health response, i.e. all of you listening to this call, including those who directly support the provision of acute care to others, might be given heightened priority. So this is something that is sometimes factored into those decisions. There are 3 levels of crisis care right now. We're definitely not under conventional standards of care. We are in kind of the contingency phase. There hasn't been a crisis declared in any hospital. We are able to take care of the patients we're receiving right now. But the line between contingency and crisis is fine. And it can only take 1 or 2 days or another nursing home with 60 to 70 patients to become infected for a contingency order of care to turn into a crisis order of care. We in the hospitals have kind of looked to professional societies for how to deal with crisis care. And this is just one example that we're using at my hospital, where we're taking people that don't typically work in the ICU and dividing them into care teams to provide care around the clock. There aren't enough intensivists to run every ICU bed or every ICU unit. So we generally have one kind of expert intensivist on, and then we put one non-intensivist who has a pretty good idea of how to take care of these patients and may have been upskilled or uptrained a little bit to run each unit with a cohort of providers beneath them. So the last slide or two is the silver lining in all of this. You know, I got to tell you that I'm impressed by everybody on this call and that I've encountered in the field. Our resiliency. I remember the first few days on the way home from work, my wife said after working 14 hours, hey, can you go by Walmart? It was the Walmart off Reisterstown Road in Owens Mills. And she's like, can you go get us some more hand sanitizer? And I kind of scratched my head a little bit, and I knew what I was going to find. And this is what I found. And I looked at the panic on people's faces out in the community. And then I thought about everybody back at work who just had their head down and was there working and pushing forward with training and simulation and problem solving and innovation. And I was instantly very proud of being part of that team. Collaboration, I have never seen in my career such a high degree of immediate collaboration between different disciplines. This picture that I'm showing on the screen is our director of anesthesia, John Kuchar, Dr. Kuchar. I'm there in front of him on the laptop, meeting with ICU staff, anesthesia techs, nurses, where we very early in this was back in middle March, started training our ICU staff on how to use anesthesia machines as ventilators. Here you see a picture of one of our anesthesia machines right next to our traditional ICU beds. And we started this very, very early in the process. And just to give you a little bit of kind of intel and insight, we have 17 ventilators at GBMC. That's not going to be enough. So we recognized that early. We collaborated, we innovated, and we have 40 anesthesia machines. So think about it. We expanded our mechanical ventilation capability from 17 to over 50 by just collaborating and working together. On the left is one of our anesthesia techs teaching our team how to do maintenance on the anesthesia machines, which are a little bit different than the ventilators to use. Information sharing has been amazing. Like I said earlier in the call, it's been great to have colleagues like Dr. Barinholtz who will send me a text and say, hey, listen, my division is getting together this morning to talk about mechanical ventilation of these patients. You want to jump on? And I jump on the call, and nobody cares that I'm there, and I ask questions, and we reach out to each other and we collaborate, and there's things that I can share that maybe Hopkins hasn't been doing yet, and vice versa. It's awesome. And don't forget, we can collaborate in Baltimore County too. We can come together, every station can come together, and we can share information. I was just in the ER yesterday at St. Joe's the last few days working, and one of the RTs came down and showed me this powerless ventilator that I hadn't seen in years. I used to use this when I was a flight paramedic back in Syracuse. But this is a powerless ventilator that just hooks up to an oxygen supply at 15 liters per minute. And in a very simple fashion, I can't show you the video now because it'll crash the system, but by dialing in knobs and pushing knobs in and out, you can adjust the rate and the amount of driving pressure. And there may be some use for this downstream. And it was cool because it came down during my ER shift, was showing this to us, and there's a stock of these available at that hospital. Some really simple information sharing early in this. I really loved the way that the ED staff at St. Joe's was storing their PPE. I took that back to my organization, and we did much the same. Some cool things that I've seen in recent days is St. Joe's, one of our primary cardiac centers, went out and they bought 2 Lucas devices. And you know what I'm going to say here is, guess what? We've been doing it for years, just like we did the IOs first, just like we did high performance CPR first, just like we've been using Lucas's. They're realizing, hey, maybe there's something to being efficient with and working with less resources and less people the way the fire department does. And they purchased 2 Lucas's, put them in service, not only to limit the amount of people that are in the room, but as a means of preserving staff that's doing CPR. CPR, particularly in patients that you don't know whether or not they have COVID, is an aerosol generating procedure, and why not limit the amount of people around the patient. Again, it was amazing. You struggle to find a facilities guy in the middle of the night to change the thermostat for a patient's room in the hospital, but yet in 48 hours, they're able to change all of your rooms to negative pressure. The grit that I've seen from every level of person that works in and out of the hospital with regard to getting it done is just simply amazed me. The teamwork, kind of coming together really quickly with my colleagues in the ED and anesthesia and in EMS and just doing collaborative training has been not only just very rewarding, it's been really nice to get to know people through more than just a phone call or a radio communication. And then just my respect and value for the people that I work with, both in and out of the hospital, my nurses that go into the room 100 times for my every one time, and really have to know how to use their PPE. The 3 nurses pictured here that are taking care of 5 COVID positive patients and still smile and know how to put their PPE on and off and go home healthy at the end of their shift because they're doing it right, because they participated in training with me and other members of our team. I give them a huge amount of credit. I have a huge amount of respect for them. And there's really been a coming together of staff the way I've never seen before. More than anything else, though, I really have come to love going home and not wearing my PPE and spending time with my family. And I've loved having my kids home from school. I don't know if my wife has. I am extremely grateful for my own family, for my work family, and I'm extremely grateful for everybody in my fire family. And I am extremely grateful to have the opportunity to present some of my learning and observations with you. And on behalf of all of us, Dr. Barinholtz in particular, who helped facilitate this conference, Dr. Pollock and all of our other medical directors, I want to thank all of you for everything that you do. Please know that we are here and we are available, and there's always the ability to reach out and speak to us through the usual chain of command. So I'd like to wrap things up. I thank you for being with me for the past hour and a half. And Sean, I'm happy to take any questions.
Yeah, so I suspect there are going to be more coming in, but some of the ones that passed a little bit time ago that are in the chat. One is a colleague, one of your colleagues, I guess, from Santa Monica, UCLA, said, have you guys seen some kind of pathognomonic red circles developing around the eyes of patients who end up testing for positive corona? I shared that we have not been seeing that at Hopkins. Have you been seeing that or heard of that?
No, it's interesting. I've had a few people get some macular papular rashes. So it's very common when kids get viral syndromes that they get what are called viral exanthems. They get a little kind of fine maculopapular rash. Right now in my unit, I have, I think I have 5 intubated mechanically ventilated patients with proven SARS-CoV-2 COVID-19. And actually 2 of them have a maculopapular rash that developed while they were in the ICU. that kind of goes along with what we see in other kind of more benign viral syndromes, often in children. One of the patients actually developed it, and it particularly affected his ear. And because of the way the ET tube securement device was kind of coming across his ear, it got a little bit of a bacterial superinfection. So we are seeing some skin changes. They're usually along the lines of viral exanthems, but I've not seen anything specific. I've seen patients develop severe conjunctivitis, which is also not uncommon, red goopy eyes when you have a viral syndrome. And remember, COVID is a viral syndrome. So conjunctivitis is not uncommon and may be expected. And then other more generalized viral rashes can be expected.
Hey, David, I've unmuted myself. Can you hear me?
Yes.
Hi, thanks so much. First of all, you're amazing. All of you. I just wanted to describe what I've been told by my ICU, by the people who run our ICUs here, and what they're seeing. Because unfortunately, here in California, we don't have the test right now. Our some shipments of PPEs have gotten, I don't know, lost, but we're supposed to get more. And so we're hoping that will come in, and we won't have that issue this coming week. But so anyway, we've just had to go back to old world medicine in some cases with our, growing issues over here and our large population. And so some of our, ICU department chairs have been reporting that there is a pathognomonic. Okay, and same thing with our family medicine clinics, the patients are coming through the family medicine clinics and then going to the ICU or the ER, but a lot of them are coming in outpatient, okay? And so what they're saying is that not a conjunctivitis, not some kind of redness in the eye or a rash. What we're talking about is an alteration. This might be helpful for more outpatient, but to catch people early, okay? Maybe who to test. But it's like a red circle, kind of like raccoon eyes, but red. That makes sense. So, right, a circular discoloration around the entire orbit, but that's red. Okay, right. So it's like a discoloration. It's not a rash. It's not in the eye. It's not in the cornea. It's not anywhere. It's just around the orbit, okay, in the orbital depression, and you'll see a change of color of the skin. And it seems to be that those patients, you can see these changes early, they come in, and by the time we test them, they're all positive.
Right. So I would just caution everybody listening that, Dr. Jane, I appreciate it. Dr. Jane is one of my colleagues. I went to medical school with her. She actually is somebody that I keep in touch with who's in California and tragically in Malibu. So cheer for that.
We don't have any hospitals here. We just had a big fire last year. So it's important. It's just send a chopper from Maryland for me.
we can send the chopper to Malibu. No worries.
Thank you.
We may have to refuel mid-country, but we'll get there. So it's important to remember. It's important to remember that there are, like you just heard, there's going to be, even from physicians, tons of anecdotal stories and information and observations. And we just have to be careful with information that we kind of adopt and hold close to our heart. It's great to share information, but you should also, what I would tell people is that we have to rely on our incident command staff, the synthesis of information through the command staff, and the dissemination of that command staff, dissemination of that information through the appropriate channels. I appreciate the input and the observation. And should we start to see anything like that locally, we do twice daily, sometimes situation reports. We would convey that to the field.
Hey, Dave.
Yes.
Another question from Joe Classic. Could you ever see us a situation where we start transporting patients in prone or oblique positions?
Yeah, Joe, so that's a good question. I will tell you this. The short answer is no. We're very blessed living in Baltimore County, even if you're up in Parkton, with having a pretty quick transport time, if you limit scene time, with a very quick transport time to most hospitals. I understand that it can be 30 minutes at the extremes of the county, but in most sections of the county, it's on the order of 5 to 10 minutes once you initiate transport. That said, I have gone on calls with our providers for people before COVID that have had severe pneumonias, and maybe they come to us from an urgent care facility where they've had an x-ray, and their right lung is completely filled with pneumonia, okay? And their SATs are low. And what can you do? You put them on a nasal cannula or non-rebreather or whatever the appropriate oxygen delivery device is, and then you have them lie in a left lateral recumbent position on their left side, because you harness the effects of gravity. Instead of having them lay on their back, or certainly worse on the right affected side, you put their good lung down or tilted down, or even just wedge a pillow underneath them so that their good lung is down. And then you can see a sudden surge in oxygen saturations by just altering the position slightly. So Joe, great question. I don't know that we're going to have to routinely come up with a protocol to prone patients in the EMS sector. But certainly if somebody is known to have horrible disease on one side of their lung and they're hypoxic, you can always tilt them, and you want to put the good lung down, and that can actually improve oxygenation. Great question.
There's another question from Jeff Coleman. Have the fire department docs been able to reach out to the medical directors and staff at nursing facilities regarding the new fire department response to those facilities?
I'm going to defer to Director Shenning and the command staff on this. I don't know if there's been specific communication from the fire department or the health department regarding those sorts of things.
Yeah, so thanks. That yeah, the short answer is yes, but not with each individual nursing home. What we're doing is we're working closely with the Department of Health, and we're surveilling through that mechanism. And if and when we're going to be able to spearhead this and know about it in advance, our district officers are calling each nursing home, touching base each morning, being a liaison with them, providing us back some stuff. So between us and the health department and with Dr. Pollack, we are reaching out when we think that there's an issue.
So there's a question I see on the line. Will people who are positive for COVID-19 who are discharged and come back for care continue to be treated as a PUI? And the answer from Mommy's iPhone is yes. Whether or not you've tested positive or negative, if you represent at any time with our defined PUI symptoms of fever over 100.4, upper respiratory illness type symptoms, you should be treated as a PUI. Crews should don and doff PPE as they would even if it was the initial patient encounter. Any other comments or questions, Sean?
That's all I'm seeing.
Okay. Well, I don't want to hold everybody up. Again, it's 11:40. It's been an hour and 40 minutes. I, again, want to thank everybody for joining us today. I want to thank our command staff for allowing me to share this information with you. And again, if there are any questions, I would go through the usual channels of communication. And if Director Shenning and folks at the Incident Command Center don't know the answer, trust me that they are frequently reaching out to us and discussing these things with us. And I want all of you guys to stay safe, stay healthy, use common sense, and most of all, just be proud of the work that you're doing and recognize how important you are to the mission. And thank you again.
Thank you very much, Dr. Vitberg, Dr. Barinholtz. Very great presentation. I echo everything that you said, and I want to, on behalf of the department, I want to thank you guys very much.
Thanks, everyone. Be safe.
Thank you. You guys are amazing. Keep it up.